Okay, that should go smoothly. So just to introduce myself very briefly, I'm Armel Pindon. My background is in neuroscience. I did my PhD in Paris, in the Hospital La Salpêtrière, and then I went to pharmaceutical industry to do some drug discovery on different areas and cloning and expression on others. Now I'm in the rare disease fields and I'm the scientific director of Cure VCP disease, but today my hat is really with CONECT, and I will guide you through our third panel, and I will start first by by explaining you what's the CONECT platform. So it's a CONECT means, in fact, cardio-ocular network on connective tissue disorder. Okay. To move that. Our panel today is about the patients and clinicians collaboration, which is, in fact, you will see when I explain, the main goal of the whole project. So what do we want to address in this project, this 2 years project? We want to address the common limitation and challenges among the connective tissue rare disorders. So we want to align the medical care with the medical needs according to the patients. So that's something very central. We want to empower the patients with appropriate knowledge for an efficient dialogue. So that's really our panel today is all about having an efficient dialogue with the clinician, between the clinicians and the patients. By that way, we think that we can identify and disseminate specific differential training for medical staff, and move this. And that's the new doctors that are confronted with connective tissue disorder. They didn't have any training or very few training during the medical school, so we need to address and try to make them aware of all the different connective tissue issues. We want to inform PCOR priorities in PCOR. So that's the verbal from PCORI where we got the grant. So it means that we want to identify maybe new ways of research, new big theme of research coming from the patients. So how we're going to do that? We use virtual convening like the one today. We listen to patients' voice to explore the patient needs and answer the challenges and make proper, so that you can make proper medical decision. We use expert clinician analysis to create the content for the masterclass for the clinicians. And we create a partnership in disseminating the platform with you, with all the different organizations, including interactive webinars and hotline, and share the observation and the information. So really the idea is to get all this information first, then have a kind of lens to focus the information that we get, with the idea that it's to improve the care through education and at the end identify new research. Then we go to dissemination, and since the dissemination is interactive, that can bring new questions or new challenges that go back in the circle. So the thing is that the model is really interactive and will allow adjusting the focus of what I call what we call with Andrea the cross-sectional issues in the similar rare communities. The platform has a direct impact on awareness in the clinical community, and an indirect impact through the increase of ability of the patient to advocate and explain with the clinician, to the clinicians. So we hope that will implement new research And I'm gonna go faster to directly what we are interested in today. It's really, we would like to address the limitations that are impacting the dialogue between patient and physician. So to the panelists, we are going to ask 4 questions. Maybe we can group them by question 1 and 2, and then go back and have the panel explain, then have some feedback from the whole audience if you think that you don't share the same experience or you have other experience. And then we will address the question number 3 and 4. So we'll start with the what specialty care physician does not take into consideration what you say, and what symptoms do you feel is not taken into consideration. So what specialty and what symptom do you have the feeling that when you explain them, they don't care about it? And then in the second time, we are going to address them where you have the feeling that you go to a specialist and he doesn't know anything about your disease or very little about your disease. So that will help us target the right specialization for the master classes. And where is your knowledge gap? So where do you feel that if you knew more about something, you could describe your symptom or have a dialogue with the clinicians in a better way or more efficient way? So I'm going to stop sharing and go back to you. So do you have any questions? Do you, is there anyone? No, it's clear for everybody. So we can start maybe with the panelists. If you could introduce yourself briefly and then go to the questions. Can we start with maybe Kim, because she's a new member.
Absolutely. Hi, I'm Kim Ventarola. I am a co-founder of the Milan Syndrome Foundation. And as Andrea was saying earlier, I obviously got involved because my son was diagnosed with Milan syndrome. And as many others, there was no answers. There was no information, very few publications. So through a Facebook support group, as we all know, that's our lifeline sometimes, I found 3 other moms that decided they would love to start a foundation together. And we are just over 4 years old now, and we are trying our hardest to support our families as best we can and spread awareness and reach all of the specialists. So the first question was, what physician what was the first?
What specialty and what symptom you have the feeling that they don't hear or take into consideration what you say?
Okay, so it's hard to name just one physician that doesn't understand what we say. I think that's a really right. So like I was saying, Milan syndrome, like many other rare diseases, is such an umbrella of comorbidities. So I think it's really difficult when we go to a physician for them to hone in on the exact symptom we're explaining, as opposed to, the answer being, well, it's because he has Milan syndrome. And that's really not the answer. We need to dig further into what's really going on and treat it. And so I would really say, if I had to pick one specialist that most families really struggle with, I would say ophthalmology. I think a lot of our families struggle with trying to find the correct ophthalmologist, low vision clinic, to get answers and services for their children. Most Milan children have optic nerve atrophy, optic nerve hypoplasia, low vision, poor depth perception, strabismus, and the list goes on. And we have families being discharged saying there's nothing further we can do. We don't know, what's going on, or it's just anxiety, or it's just because of their developmental delay. And they're not digging further into what's really going on. And with little publications, that's a big problem.
Very much agree. And I could not second that anymore.
Yeah, I didn't want to limit you to one. You can.
I could go on the whole time.
in the survey, we asked for 3, I think, Andrea. Was it 3 or 5? 5, I believe.
We had 5, so let's stick to the top 2 or 3 if that would work.
Do you want me to keep going?
Yeah, maybe if you can
okay.
give us
yes, absolutely. So I'll give you another one. I would say neurology. I think a lot of us have abnormal EEG findings, abnormal MRI results, and unless it's something extremely significant, it's reported as non-specific findings. But if 50% to 75% of the community have non-specific findings, it's clearly not non-specific. So that's another big issue we're having. Also, seizures is very underreported. So we only have, I think, reported in the literature at this point about 30%, but in our patient groups, we're seeing a very, much higher incidence, and families are, reporting things to their neurologist, like different episodes, and it's being just downplayed, like that doesn't look like it. That's a processing delay, or that's just their vision, or, it's very, unless you're catching something on an EEG, which we all know is extremely difficult to do, it really limits what's happening. And I would say the other specialist, I don't know really so much a specialist, but I know connective tissue issues is a big problem for us. We're really just that we're hitting the surface with that now. We're hearing all of these things going on. We're experiencing them as parents ourselves, and we can't get answers. Well, I was told, well, that's really just such a broad term that, that was the latest thing that I just heard. Or dysautonomia is another big one. Like that's, well, that's broad, that could be a lot of different things, or it could just be your child, it's just different things. It's constant dead ends. And without, us all coming together to really raise the bar, we're really going to be stuck. So this is great. And I love this collaboration. And I think that we're going to make the change.
I completely believe that we will. Just the things that we're seeing behind the scenes and the surveys, there's definitely correlations there. And when Armel and I sat down to write this program out, we kind of had an idea of, especially with, Armel comes from a different group, so she can see it from like an umbrella kind of perspective, and me being down on the ground, like there's things that I saw that were similarities between the groups, but nobody was talking about them. And now we're going to start having those conversations. And, even though this is just a 2-year project for that particular purpose, I think CONECT is here to stay. Like this is going to be a huge movement forward for all of our patient populations to be able to work on these issues together instead of trying to combat them differently. So I'm very excited to have everybody here. I'm sorry, I will quit talking, but I just wanted to, give you the I don't know, the high five there, because that's exactly what we're all feeling, I think.
Yeah, you have to thank Andrea for thinking about getting all of you together, because I was really going on another more technical aspect, and she said we need to gather all of them and put them together, and we'll get a lot from it. And well, that's a success. We are getting a lot, so kudos. Next one, because we are limiting in time. Ines. Do I say it right? We say Ines in French.
Yes. Ines.
Ines. Okay.
Portuguese. My accent is missing on the E.
Okay.
Ines.
So Ines, can you describe your experience in Myhre syndrome?
Absolutely. Hello, everyone. There are some people on here who also have children or with Myhre. Andrea, the other Andrea from Italy, we've never met. He just joined our Myhre syndrome Facebook group just a few days ago. Just found out his son was diagnosed with Myhre. So thank you so much, Armel and Andrea Taylor, for putting this together, because you're bringing people together from around the world that we haven't even met yet. So my name is Ines White. I am the president of the Myhre Syndrome Foundation, and Kate Wares is our executive director. Much like everyone else here, Myrie syndrome is extremely rare. We think maybe 200 cases around the world. And our foundation was also founded 4 years ago by Kathy Young and Justin Smith, who both have children with Myrie. And they brought me on probably a few months after they created the foundation. So we're a very young foundation. And our foundation focuses on research and advocacy. So we have a professional advisory board. And Armel, I have to tell you, you remind me so much of Dr. Lynn. Dr. Lynn is our wonderful doctor who created a Myrie syndrome clinic in Boston at the MGH. And you remind me so much of her, your passion for helping our communities is I just hear her when you talk. I hear Angela. And our foundation has this professional advisory board of doctors from around the world. So we have a doctor from Italy, France, Belgium, Sweden, and they're such a help to us. However, because Myrie is so rare, much like Kim, it happens every day. Like Andrea is like a case where he came onto our group just finding out his son had Myrie, looking for help. And luckily there are families in Italy that are in that Facebook group, and they've connected with him and provided that support as far as the medical community is concerned. But much like him, Katie is my daughter. She's 24. We are desperately looking for doctors who will take interest in the future of Katie. They when we go see a doctor, they want to treat what she has today. So she has a cold. Okay, we'll treat that cold. When we go to see the pulmonologist, they go, what are her symptoms today? And I'm like, no, it's not just about today. I need you to set a baseline because it's going to get worse. So she just recently went to see a pulmonologist, and he did the test only because I asked him to do the test. It wasn't okay, let's look, how did she do last time? And again, I had to ask for the test, and it had been 5 years, and she should get a test every year because pulmonology is an area of concern. Cardiology is an area of concern. The skin condition, the hardening of the skin, which is very, very important because our kids, when they go through surgery, when they heal, their scar tissue builds up really quickly. So it's very, very hard on their bodies. We have a young man right now, Kingston, who's in Florida, and just yesterday was fighting for his life. He had open heart surgery. It sounds like he's doing better today, thank goodness. So Kim, you sounded just like us. There is no doctor that has ever met Katie that said, oh, I know what to do. Our foundation created a handbook, and I would love for anyone on this call, if they don't have a handbook, to talk to us, because we would love to show you what we did. We created a handbook that has a checklist of all the specialists to go see. And because of a grant, it's translated into 6 languages, I think, Kate, right? Italian, Spanish, German, French. And you can take that handbook. It explains Myrie. You can give that handbook to your doctors and say, if they're interested in reading it. And then it has a checklist of all the specialists you need to go see. It explains different types of issues that you will encounter with Myrie. And Myrie is different for everyone. Like my Katie, thank goodness, had minor things, but is not yet critical. But we have to watch her because she's getting worse. every year it's getting worse. So I would say those are the doctors to focus on. And Matt Cantor, who's on here as well. Hi, Matt. He has a little boy named Henry, and oh, there he is. There he is. And just last month, Matt and Henry were at the hospital together and joined us for a coffee hour that we do every month. And it's scary. It's scary how much our doctors don't know. Really scary.
So, so you would say that there is, in fact, no specialist that's not specialty that really know about. It's all the specialists that don't know anything about.
There are two locations where I feel in the United States, and obviously there's our professionals outside, ones or twos out there. Dr. Lynn, again, has the Myrie Clinic at MGH in Boston. And then there's a Dr. Lisa Scamenti out of Minneapolis, geneticist. She's following 2 adult ladies who have Myrie in Minnesota. I'm trying to get Katie to go see her. They're really the only ones that you can go see and say, and she has already lined up all these doctors for Katie to see if I could get approval from South Dakota to let her go there. But there are no doctors out there that can tell us, apart from those 2, that can say, okay, these are all the tests you need to take.
Yeah.
Well, on a professional, I'm so sorry. On a professional level, I know Dr. Scamenti, and I cannot praise her enough. And if you have the opportunity to see her, and if I was in the position that I needed to see someone, she would be the first person I would go to. She is amazing, and I cannot give enough kudos to her. So sorry, I didn't mean to jump in, Armel. I just
know her.
Yes, I've worked with her in the industry, and so I've come across her quite a bit, and I have the utmost respect for her, and she is phenomenal. She is like, we called her the house of genetics, kind of, because she just really takes so much time and so much care with her patients. And from a professional side of things, I cannot commend someone any more than that. She's amazing.
Just to jump in and add experience from this week. Our team of doctors in San Francisco are amazing. And I think I have great interactions with them. But I will show you an example. This week, we went to see his endocrinologist for, my son has Myrie as well. And I went in with a list of things I would like her to look at. Now, if I hadn't and had gone to her and said, great, how are we doing? She potentially wouldn't have ordered the tests and done the x-rays that I required. So it's the onus is on us to educate the doctors each and every time, because there's never been a doctor, and this is with the most respect and love for the doctors that we see, they have not knowledge of all the 9,000 rare diseases. If I don't go in prepared with the information that I've gathered from our community or from the handbook, then we might miss something. So the onus is on me to be prepared for the appointment. So when that's happening, and that's great, we're on top of things. But if we don't know what to ask, then we could be missing something.
Yeah, so that points out the necessity for the patient to be really educated and know their disease. So everybody says the specialist is the patient. So what you can do also is, instead of having a whole handbook, having a card, a small card with the QR code of your standard of care or your handbook if you don't have the standard of care published, so that you can easily give this the little card to the different doctors, and just with the QR code they have access to the whole standard of care. But definitely that points out how patient education is fundamental for these very limited, very few patients on those ultra rare diseases. That's crucial. Okay, so that doesn't pinpoint where we should focus for Myrie. in fact, we should have a whole project on myori.
I mean, I would say in terms of if you want to pinpoint and say the most importance for us that people do understand what's going on is cardiology and pulmonology. And if people are not looking at those things carefully, there are some danger points that we need to be on top of with those two areas. So yes, they are the two most important things for people to be on top of and getting checked. And if your cardiologist and pulmonologist isn't on track with myri, that could be detrimental to you or your child's future.
And Andrea, is Christian here? I don't see him.
He was just a moment ago. Christian, are you still here?
Oh yeah, I see. Okay.
Yes.
Hey, Christian. Good morning.
Morning.
Christian has arterial tortuosity syndrome. So would you like to share the feeling you have about who really doesn't understand when you explain your symptoms, and which kind of symptoms you have the feeling that they just ignore?
I don't really know. I mean, I explain it to my father, and my father don't really understand whenever I try to explain it to him. He thinks it's something that's curable.
No, but in terms with the doctors, do you have the feeling that when you go to the doctor, there is something that bother you, and they just say, well, that's part of the thing, and they don't pay attention? No? Oh.
No.
Christian, how do you feel that your local doctors handle it? I know you have amazing care at Arkansas Children's, and they have your cardiac things under control. But how do you feel when you have to go for, an emergency type situation at your local doctor? Do you find that they understand what's going on with ATS and you?
No, because every time I go to the doctor up here, we got to call Little Rock because they don't know what they're doing up here in Ripley. Like every time they got to approve something, they got to call Little Rock.
So what type of doctors do you generally see in Ripley?
Family doctor.
Do you think that they, it's great that they're contacting ACH so that you've got a great support system. Didn't you have like something come up a while back with your lungs and you had to see a different doctor and they weren't sure what to do, or?
Yes. They said I got to go to a specialist, and that's the same with my kidneys. They said I got to go to my family doctor up here and get them to call a specialist. I got to get seen at my family doctor before they can refer me to a specialist.
So do you feel, have you gotten to see that new specialist yet?
Not yet.
So how do you feel like your family doctor is able to take care of you with your symptoms at ACH? I mean, they're getting support, but do you think that they understand, your symptoms? Are they taking care of them?
They're taking care of me.
Good. So how do you feel about ACH? What do you feel like your care is there?
Well, it's pretty good care. They take care of me. I've been going there for almost 14 years next month.
They are a great facility, and they definitely saved Aiden's life, and I know they did yours, so I'm very, very grateful for them. Is there anything that you'd like to tell us about what you wish was different? Like if there was a treatment for something, what would it be?
You talking about my eyes or anything?
Anything. What would your one thing be?
To get my left eye to where I can see again.
Very understandable.
Well, thank you, Christian. So what we can take from that is that if you go somewhere and you have the feeling that they don't understand, what could be very useful is to have a clinic that is where the specialists are, a kind of multidisciplinary clinic where any kind of doctor you go see can contact and have the reference and have the explanation. So that might be also another way to get them know more about the disease. If I understood properly, that's what you do. I don't know, Andrea and Christian, you're going to do.
You're very correct, Armel, and I commend what you're saying very much so, because you are taking exactly what Christian is saying. If you have physicians that don't understand, or you're seeing a new physician, but you do have that multidisciplinary approach, or you have a team that really knows what they're doing with your condition, ask them if it's okay if your patients share their email with their own provider, or they work with you to share the emails amongst the providers, because we have found that that has been the most beneficial thing that we could do. So Christian doesn't have to live in Arkansas. He can live somewhere else, but his specialists are in Arkansas, just like ours are. We live in the Tulsa area, and we actually moved here because we felt safe enough that we knew that we had that multidisciplinary approach at Arkansas Children's. And if we needed something, we could get help right away. So if the patient group leaders, if you don't have that kind of resource or relationship started with your providers, I would highly recommend doing that. It is a great benefit to your patients.
Thank you. Maybe Dave, if you could share with us where you think that some of your symptoms were ignored, or when you have the feeling when you go to a certain type of specialist that they really have no clue about your rare disease.
That's the stuff, they have no clue. Hi, I'm Dave. I'm also in Boston. And I have cutis laxa, as does my sister's, which is a connective tissue disorder. In my case, and her case too, it showed up in the heart. So we see cardiologists a lot, as well as pulmonary. We were both birth defect babies. We had open heart surgery as 5-year-olds. So I'm sure some of you can identify with that. And then everything went along very well until I was about 60. And I got a nasty case of pneumonia out of nowhere. I was on a business trip and ended up, I was in Houston in their hospital, and they did a chest x-ray and determined that I had this large aneurysm. No symptoms. In fact, I just had it repaired. My 1-year anniversary, I got a new aorta last February 11th. So there you go. Not the whole thing, but parts of it. When I went in for the surgery, I still had no symptoms. So if I had not, pneumonia saved my life. If I hadn't done that x-ray, they would have never known I had the aneurysm. And by the time it was diagnosed, it was 4.2 centimeters. 5 is when they do the surgery. But I was sent to Mass General, to the head of, actually at Johns Hopkins, Emory, and then finally Mass General, to the head of cardiology. And I took my daughter with me. My daughter, I'm her patient. I always tell the story that I had to make my own genetic counselor who diagnosed me, but I had to wait 40 years. So my daughter is a professor and a geneticist at Emory University and runs a clinical trial center there. So when I showed up with this aneurysm, I had my sister get an echocardiogram, and she had the same aneurysm. So that's when people started thinking genetics. So being born before there were genetics, now we're just getting around to finding that. So I got my daughter interested. We did full genome sequencing, and took 3 years, but we finally figured out cutis laxa was the thing. We knew it was connective tissue. We didn't know which one. And that led to the open heart surgery. But about knowing, my cardiologist you always get this first question, right? You say, I have cutis laxa, I'm different. And they say, could you spell that, please? You know, you got a ways to go, right? To educate them on what it is. And similar to what I heard from the other discussions, when I first was diagnosed, we had a small group in Europe, cutis laxa International. We had maybe, I don't know, 20 people. We're up to 400 now. We get about patients serendipitously a month, give or take. Somebody meets somebody and they get into the group. But actually the year before, the year before my surgery, I took my daughter with me to meet the cardiologist to say, I know I have a plumbing problem, you're going to repair my aorta, but I have a connective tissue disorder. I have soft tissue that may make a difference, because we probably never worked on anybody like me. And he said, well, you need to go talk to our genetics department, but yeah, I have a scalpel. I'll fix the problem when the time comes. He did hear me though, which was a good thing. And when it finally came time for the surgery, he assigned a surgeon that had come from Johns Hopkins from the connective tissue practice. So he knew connective tissue. So it made me feel a lot better. I still didn't know what the surgery would be like, but there was some understanding. My primary care physician, the first time he saw my record, said, "Boy, you're in good shape for what your records say," because there's so much in there. So they don't have time to spend and understand. And my record says genetic counselors are a good place to start if you can find one that knows your condition, because they'll spend the time with you to figure out what's going on and try and help you. Primary care physicians and specialists, you get your 10 or 15 minutes and then you're off to the next thing. So I think that's kind of the way I look at the experience. I don't know Armel, what else would you like to ask? Because I can go. Oh, you're muted.
Yeah. Difficulty with the new computer to handle the thing. No, for the first part, that's really, I think everybody's going towards the general practitioner doesn't know anything about your disease, and then the specialty, the most efficient, in fact, if I understand properly, is that they refer to other centers that are more specialist and know about the disease. So when they are smart like that and don't ignore the fact that you have ultra rare and go to the specialist, the only one in US or the two only one in US, that's a good way to go. If I understand properly, that you have good experience in that case.
Yeah, I think you have to really stay on top of it. You have to keep pushing, and that's what everybody's saying, that you have to be the advocate for yourself or your child, and then you can't let them off the hook. So
yeah. Sorry, I don't want to rush, but we have limited time, so I don't want to be rude, but Gina, you're from, you have Marfan syndrome. If you could share also your experience.
Yes. Hi, good morning. I'm Gina. I'm from the Los Angeles area, and I was diagnosed with Marfan syndrome in 1987 after my mom died from an aortic dissection. She was the first in my family, and I'm her only child, and I have not decided to have children because of Marfan syndrome. So I decided to stop the link there. My experience with Marfan syndrome has been unique in that because my mom died at a very early age, and we were very fortunate to have the Marfan Foundation start in the early 80s. The Marfan Foundation published a giant notebook of all of the information about Marfan syndrome related to, especially, the heart and the eyes and the spine and the back and all of the systems that were impacted by Marfan syndrome. So as a young child, 7, 8, 9 years old, I devoured that resource and read it over and over and over, knowing that I needed to teach the doctors that I was going to see about what I had, and that I needed to remind them of the documentation that I was given about my syndrome and how to care for me. So my whole life has been advocating for myself and pushing the doctors to explain why they want to do a particular test or why they don't want to do a particular test. And I have encountered so many doctors who, when I meet them for the first time, it is frustrating for me as a patient because their doctoral authority, their doctoral pride gets in the way. And they say, I'm your doctor now, and I'm going to treat you now, and this is how we're going to do things. And I think, no, 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 you are not going to do what you want to do because you don't have enough information. So I have gone through many, many doctors who they told me that I was going to be their patient. And I promptly said, thank you very much. And I never returned. Fortunately, the Marfan Foundation has been able to blanket the country as best they could with information about Marfan syndrome. And in the late 80s to the early 90s, there was a big push about educating emergency rooms. And so the Marfan Foundation distributed literature to as many emergency rooms in the country as they could to educate the emergency room doctors about what a patient presents with when they are coming in with symptoms that may be of an aortic dissection or of a collapsed lung or of, something serious like that. Fortunately, they were able to get a lot of information to emergency room doctors. However, there are still, to this day, too many emergency room doctors that have no idea about Marfan syndrome. And so I've talked with other patients in the, Facebook support group, and people will comment, I went to the emergency room and I was having X, Y, and Z symptoms. And they told me, to just go home because they thought I was just having a panic attack. And that is terrifying for me as a Marfan patient who is knowledgeable about an aortic dissection and those symptoms, if they are not managed immediately, what the ultimate outcome might be. So we have a lot of work to do in educating our emergency room doctors and even the cardiologists who work in the emergency room and the pulmonologists who work in the emergency room and the orthopedists and the gastroenterologists. A lot of Marfan patients battle irritable bowel syndrome. Well, irritable bowel syndrome is just a blanket statement that we really don't know what's going on with your bowels, and they're not functioning correctly. Well, why? What's going on with my connective tissue? What's going on with, my genetic composition that is impacting my intestinal system? I frequently have had struggles with cardiologists who they have no idea about Marfan syndrome. And so Marfan syndrome is a subspecialty of cardiology. Marfan syndrome is a subspecialty of ophthalmology. That I went to a new ophthalmologist and I told her I had Marfan syndrome, and she Googled it on her phone. And that didn't give me a lot of comfort. However, I was glad that she chose to Google it in the moment instead of just take on that prideful, I'm your doctor and I'm going to take care of you stance. I was encouraged that she at least chose to research what Marfan syndrome is and how that can affect my eyes and my ocular system. But it is very discouraging to continue to see in the year 2023 that Marfan syndrome is still unknown in the specialties that are most critical to our needs. And especially, neurology is another area. A lot of Marfan patients struggle with migraine headaches, and there's some information about the tissue in Marfan patients in the brain. However, finding a neurologist who knows that is very challenging. So there are a lot of obstacles patients with Marfan syndrome face in getting the correct treatment, the most effective treatment, not being dismissed that your symptoms are an anxiety attack or that it's all in your head. I've been told that before, that, oh, it's all in your head. What's really going on? Pain management is another area. A lot of Marfan patients struggle with our bodies. They just hurt. They ache. They're painful. And pain management just wants to give us opioids or other just general pain management medications and strategies. And so trying to find effective treatments for pain management and orthopedic issues can be very challenging.
Wow, thank you so much for sharing all of that. That was absolutely amazing. And I took something from that was very interesting, that is something that, you know, I've had to deal with a lot with my son with arterial tortuosity syndrome, and I run the nonprofit. So it's very odd when you're in a position when you are seeing a new physician for whatever reason it is, and you have to educate them and they have to get their phones out and Google your condition. That I know on this call has probably experienced that at some point in time. You go in and see your doctor and they have to stop and Google what it is. Thank God for Google. But I think that this is a start where we can do much better to start trying to push education out there further. But thank you so much for sharing that. The entire presentation was fantastic and I appreciate it very much.
Thank you. Thank you for having us today. This is really important. You know, it's the beginning of the conversation to education of patients and clinicians as well.
Yeah, thank you, Gina. So listening to all of you, we still have to listen to Jade for FG1. But something that popped up is, would it be useful to have something like in diabetes, having a bracelet saying I am connective tissue patient, and having a kind of QR code on the bracelet when you go somewhere, when you go to the emergency room, that they know that you are officially part of a rare disease, and they can go through the QR codes and have a kind of list, and it makes it official. It makes it, I say serious. It's not that you are not serious when you go to the emergency room, but it gives a kind of validity that officially by other doctors, you have a bracelet saying that certain things have to be taken into consideration. So it's just an idea that pop up like that. I mean, maybe that's rubbish, but maybe we could think about something more official when you go somewhere to prove the doctor that it's not in your head. It's not something you invent. You are really part of a whole rare disease group of patients, and they can do that and that and that and that. So that's just an idea. The other idea would be, I think if we could do a kind of hackathon with all the geeks in software and blah, 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 and try to have a software where we can have all the diagnostic differential from rare disease, and not maybe all the rare disease, but let's say of connective tissue, so that you can distribute the software to general practitioner or other, so that they can, when you come for the first time, well, you have the opportunity that you know what your child or yourself, which disease you have been diagnosed. But for people who've never been diagnosed, maybe having this kind of software, it's just an idea I have now, but to help the general practitioner do a differential diagnostic, maybe that could help. But that's another project that Andrea is going to write for PCORI, huh, Andrea?
There's so many ideas here, so.
So our next panelist is Jade Day. I'll let you introduce yourself and help us.
Osio. I'm Jade Day. I am Vice President of A Twist of Fate, and I am also the authorizing officer on this project. I'm an X-linked carrier, and I'm symptomatic of a variant on MED12 that causes FG1 syndrome. My oldest son has FG1, and we've had a disagreement over this discussion of who doesn't listen to him the best. He says the vision, the optical, and I'm more on the GI, but I agree with everybody where they're saying everybody doesn't really listen to us. He says with his optical, he's dual diagnosed. He has FG1 and cerebral palsy. So they always want to default to the more known condition where they're constantly saying, oh, that's a cerebral palsy, when from what I know from studying FG, because we have nothing literally, that it's FG, not his cerebral palsy. But they like to default to the easiest diagnosis. And for me, GI is such a struggle because children with a variant ABD12 really struggle with constipation, failure to thrive, a lot of GI issues. And we have had in the past and currently, when these children go into failure to thrive, nobody, there is no experts for FG. So there's no one your doctors can contact. So a lot of these parents are getting CPS calls for failure to thrive. Like they're starving their children when they're not starving their children. It just kind of plays the part of FG. We have a real issue currently with that with a few patients. And like everybody else, cardiology. I've had the doctor walk in. I Googled it, and that's when Google was kind of new. I was like, this makes me feel real confident you're going to cut into my kid's heart. It's real confident there. And then, of course, neuro, and we have migraines that we have yet to get under control. We've tried numerous med combinations, but I'm an echo of what everybody else said. It's like everyone doesn't know a thing unless you have a good care team that has specialized in your disorder. And FG is so rare, we don't have anything. We're just starting to have people wanting to do minimum research.
Jade, if I may ask a question, do you have also tumors, like benign tumors? I don't know, I'm not a specialist of your disease, I don't know. Really.
Yes, that's another problem we have. A lot of specialists and doctors want to research that part and don't want to deal with the syndrome side, because that part's kind of interesting. So they want to go there and said syndrome. But yes, I have had benign tumors. I've had granulomas that I've had to have removed from my skin long before I even had Gavin.
So that's really interesting, because I was asking that question because the list of different symptoms that you are mentioning are similar to another rare disease, which is neurofibromatosis, where you have also failure to thrive, ophthalmologic problem, skin, small tumors, benign, but that might transform later on to malign.
I was about 19 or 20 when I had my first. I had a small little cut come up on my finger. I thought it was a cut, and it grew and grew, and it was actually a hemorrhagic granuloma that it took 4 months for them to silver nitrate it, and then finally just surgically removed it. because they could not get it to go away.
Interesting. So, sorry to be rude again with the time. Thank you, Jade. That was very useful. So is there from the audience anything that you would like to share? I don't want to exclude Andrea. Andrea, vuoi che tradusco qualcosa? Vuoi dire qualcosa che posso dire agli altri? Devi togliere il... non ti sentiamo. No, non ti sentiamo.
Ah, ok, mi sentite adesso?
Sì, perfetto.
Grazie, no, perché ho partecipato ma non ho capito perché non so l'inglese.
Sì, ma ti posso fare un assunto dopo.
Sì, perfetto. Sì.
Un'email, Kate, al mio email, mi mandi un'email e ti faccio, possiamo fare anche un Zoom. Ma vuoi dire qualcosa sul fatto che magari quando vai dal dottore non veramente non ti ascolta, o se hai l'impressione che ci sono delle dottore che non conoscono nulla alla tua malattia?
Guardi, l'abbiamo scoperto talmente così presto, 3 settimane fa, che noi stiamo facendo le visite. Stiamo facendo le visite, fatte tutte le visite, e portiamo tutto al dottore. Però il nostro dottore fino adesso è bravissimo, quel poco che l'abbiamo sentito. Andrea ha fatto una visita al cuore adesso, quella più importante, ed è andata bene.
Okay, so if I'm going to translate, so he was diagnosed only, his son was diagnosed only a few weeks ago, and up to now they have the very luck to go to doctors that understand everything and seems to be handling the disease properly. So, allora non hai mai avuto un incontro, diciamo, brutto con un dottore che ti dice no, non c'è niente, è normale? O...
Ah, sì, perché in 9 anni noi facevamo dei controlli perché vedevamo delle anomalie in Andrea. Parlava male, era, diciamo, ipertono, duro nel corpo. Spero che mi spiego bene, scusate.
Sì.
E sì, era capitato un dottore che era mandati anche a pagamento, però lui ci disse tutto a posto, è una cosa normale.
Ok, allora sarebbe bene avere qualcosa che puoi spiegare ai dottori che ha il tuo figlio. È un figlio,
Sì,
una figlia o un figlio?
Figlio maschio, Andrea, anche lui si chiama. Comunque noi l'abbiamo scoperto 3 settimane fa circa, e da un dottore bravissimo, molto bravo, che spero ci aiuterà molto.
Okay.
Ce l'ha detto lui di questa sindrome, noi non sapevamo neanche che cos'era, siamo noi che abbiamo fatto un po' di ricerche.
Ok, grazie, molto importante. Torno in inglese se non ti dispiace.
Vai, tranquilla. Io rimango anche se non capisco, vi ascolto.
Okay. So just to summarize, what he said is that his son is 9 years old, and he has been through doctors saying that it's nothing, and then really he was rejected by the doctors because they weren't able to do the proper diagnosis. So I think it's a story that you can share with so many other of you, taking years to get the proper diagnosis with their kids. And he had just a comment that is nice for typically European. Even a doctor that he had to pay didn't know about the disease. That's something for European, because it's mainly free, usually, the doctors.
Armel,
yeah.
Can you please tell Andrea that we wish his son a happy birthday? He just celebrated a happy birthday He just posted a picture, I think it was yesterday. So we just want to say happy birthday.
Andrea, è il compleanno del tuo figlio?
Sì, ieri.
Sì, allora c'è
Ieri, 9
tutta la
anni.
fondazione che ti auguri tutte le belle cose per il compleanno del tuo figlio.
La ringrazio, noi comunque siamo molto preoccupati e speriamo bene.
Ma è una bella fondazione, si andrà davanti.
Ma noi posso dire una cosa?
Sì,
Noi
sì.
adesso, allora, abbiamo fatto, come dicevo, la prima visita al cuore è andata benissimo. Ma noi avremmo altre visite più in là, ai polmoni, all'udito e tante altre, e sicuramente qualcosa riscontreremo.
Sì,
Non so,
sì.
è una domanda questa.
Ma il meglio è che facciamo un Zoom con la tua fondazione per sapere un po' di più, perché qua ora tutti sono per un altro,
mi scusa,
un altro scopo.
non ho capito.
Di sicuro facciamo qualcosa dopo per fare la traduzione fra loro e te. Ok?
Ok, va benissimo.
Ok.
Va
So is there any more comments? Some other in the audience that would like to share something that was not mentioned? No, so we can go to the next step. That would be more on your side. Where do you think you need help and more knowledge to be able to explain the symptoms? I know that some of you said that they, like Gina, who read the whole handbook, so maybe you don't need any more educations. But for the organization that do not have this kind of handbook, or even if the handbook sometimes is a bit obscure or difficult to understand, where do you think you would need some education in what part? I'm not talking about art history, but really on your disease. So we can start again from the first one was Kim.
That's fine. So like Inez, we also have a professional, we call it a professional guide, and it's translated in 6 different languages, and it has a lot of the specialists that should be seen. We also just created a newly diagnosed welcome packet for the families that includes an abundance of resources. It explains Milan syndrome. It has all of the publications hyperlinked with QR codes. It has IEP, a whole accommodation list for Milan syndrome. We'd be happy to share it with anybody that, just email me. It's in the chat. But that was our big project this year. It just has a bunch of our webinars that we've had, and everything's hyperlinked or QR code. You could take one page with you to the doctor, or you could share the whole packet with the doctor or specialist. But I think going from that, even with those resources and having, the professional guide or a handbook, we've found another area that we're starting to focus on in our next big project is it's great to have all those specialties, but now it's, well, what do we ask at the specialties? That's the big question that keeps coming up. And you see it a lot in the Facebook groups. I'm going to the gastro, what should I ask? Or I'm going to the endocrinologist, but they, they won't see me because there's no publication. So they don't know anything. Why is it related to Milan syndrome? I need this referral. How do I get it? So our next big project is putting together cheat sheets for every specialty and coming up with the tests that should be, done and the questions you need to ask and with some knowledge backed up, for it. And even though there's not publications, we are hoping and we pray that because it has the foundation's logo and we're reputable and getting out there, that they will take the patients seriously because, I've been there and I hear it through all of you. We've all left so many different doctors, and I use the term divorce, like I like to divorce doctors. And it's a shame because I think I've seen for my son, we live in New Jersey. We have access to a lot of really, really great institutions. And even at the best institutions, we've been dismissed. It took me 4 ophthalmologists, well-known, very well-known ophthalmologists, to get an answer for my son, who's legally blind, learning Braille now at 7, and they just dismissed us, you know. And I think without me pushing constantly for every specialist, for x-rays, cardiology, you know, just these our patients and our parents are the educators, and we need to, I know it's our duty to provide all of those resources. The other big one that I would say that we have on our radar, but how to get it across, is the markers for when the children are born. They're there, but they're overlooked because they're not these big, huge markers. They're not, you know, they don't require surgery. It's as simple as failing the newborn hearing screening, having a vascular anomaly, you know, long fingers and long toes. There's a lot of work to do and where to access it. But I would say the emergency room was a huge one, Gina, that we go, and sometimes we've driven my son to CHOP an hour and 15 minutes away as opposed to our local hospital because it's just easier. They have his records. You know, it's just the battle of constantly educating gets defeating. I have a rare disease myself. I have sarcoidosis. So I'm very well aware of the battle, and just being like, I'm not going to go. I'm just not going to go because they just dismiss you. And it's a horrible feeling as a patient and as a mother to a child of a rare disease. So that's, I can go on and on, but I know we're pressed for time. So that's my 2 cents on that topic.
Thank you, Kim. That's, yeah. That's something I wouldn't think about, how to get a referral. That's I mean, I'm not in your shoes, so but that's a very important piece of information. Ines?
Unmute there for a second. It's hard to follow Kim because she says everything that I'm thinking, and and gosh, I hate to tell you, Armel, you brought this group together, and we are so alike and so connected. I'm taking down notes because I think our checklist probably can be done a little bit better. So I am going to reach out to you to get your booklet and share our booklet with you as well, because it was our first version, actually second version. So we can make it better. We can make it better for, you know, for everyone around the world. I don't know. I mean, I can't add anything to what Kim said. We were a military family. The first geneticist who saw Katie, she was only 1. And the first geneticist we saw in Germany said, there's something there. I don't know what it is, but there's something there. So she sent us to a German geneticist. He said the same thing, there's something there. And every time we moved, I went to a new geneticist. Katie must have seen, well, we made 16 moves. So 16 geneticists before our very last duty station in St. Louis, Children's Hospital in St. Louis. And Dr. Pai said, I am not going to give up until I know for sure what this girl has. And he sent his students out. It's a teaching hospital. So he sent his medical students out and said, go find out what this is, you know? And all of a sudden I was sitting in Taco Bell's parking lot with my husband, and he calls us and he goes, we know what it is. And the only reason he knew what it is they looked up pictures, and all of our kids look alike. They all look alike. All of our community, they all look alike. And so I'm like him. We've got to educate our medical professionals. I actually just got an idea. We live in a little town, and eventually Katie's going to have to go to the ER. There's just something's going to happen. She's going to have to go to the ER, and maybe without me. So having that bracelet, but also going to the ER to her And before they try to stick a tube down her throat, they need to know it will damage her trachea if they try to stick an adult size tube down her throat. It has to be the tiniest tube, or they will damage it to her detriment. If they damage it too much, the scar tissue will cause it for her to eventually have to have a trach put in. So you guys have given me so many ideas, but we need to educate we're so rare. We go to panels, we talk at medical schools, educate. It's not just educating our own physicians, it's educating around the world, which is why we do virtual conferences. We're going to have an in-person conference in 2024. The knowledge gap is so wide because we are so rare. I don't know. I don't know how we're going to fix that particular, the QR codes. The reason that I bring in hard copy and put in the hands of the physician is they can't ignore it. They can throw it in the trash if they want to. But I cannot make it easier for them than giving them the handbook in their hand and saying, you need to research this. You need to tell me the next time I come with Katie what tests you're going to do. I shouldn't have to constantly be reminding you. And now that we're no longer in the military, hopefully she'll be seeing the same doctors. Hopefully she'll see Dr. Scamenti. But what's really missing is in our rare world, Armel, are doctors who say, I will take this on. You are so rare. I'm going to create a team to follow your child, especially when we know that this is going to get worse and worse and worse. And it's sad that I am on so many.
I am so sorry.
It's okay. It's all right. That we have to go through so many geneticists to find someone, and it doesn't have to be a geneticist, but a doctor that says, I know Katie's going to get worse. We need to track her now so that we can attack, her next potential crisis. Kingston, who's in the hospital in Florida, 2 weeks ago, he was digging sandcastles and making sandcastles on the beaches in Florida. And now he had open heart surgery. And if it wasn't for the mom having a link to Dr. Lynn in Boston, and the surgeon in Florida, this is crazy. The surgeon in Florida called Dr. Lynn, and she gave him advice that changed the way he was going to do his procedure. Mm-hmm. Crazy. That is crazy. That he didn't know that. He didn't know. He didn't reach out to her. It was the mom who said, you need to reach out to Dr. Lynn. She might say nothing, but she might give you advice. And they completely changed the surgery, which actually saved him from having to go to another surgery to do what Dr. Lynn told him to do. Mind-blowing. Mind-blowing. That we have to go to Dr. Lynn.
And there's just to follow on that, they were lucky that they were both in the same country. Now, if that situation had happened, whether it was a family outside of the US, Dr. Lynn's capability to talk to that doctor would be impacted. So there then is a different care situation. And again, that's what we need to overcome and help facilitate as well, because, we are, representing internationally. And it just so happens that our clinic is in the US, which is fantastic for US families, but we need to bridge that gap for the rest of the world as well, as much as we can. And just to add on that first responding situation as well, I think the bracelet and things like that are such good ideas, because also when you're in a high intense situation of being in the ER, as much as we know, we might not be able to articulate exactly what we want to articulate in an emergency situation. So giving ourselves something to refer to, for us, if they're presenting with symptoms, acute pericarditis, the filling of the fluid around the heart sac is a danger point. We need to be able to explain that efficiently so that they get that check straight away. It's quite a simple check, but if we can't get that across, they don't believe us or whatever. Those are the types of things. So that first response, I think we've all hit upon something here about what can we do in those first response situations too.
Yeah, The thing is that, which is obvious, is that we cannot educate all the physicians in the world about every single rare disease. So I think this idea to have the expert center, a clinic expert center where all the different doctors can refer to and have their, get some advice or have some help would be something to consider for ultra rare diseases. Maybe if you can have 2 in the US and 1 in Europe, that would be already something important. Well, yeah, great remarks. After Ines, we have Christian. So Christian, is there something, a domain you would like to know more that would help you to express in a better way your symptoms or have a better dialogue with your physician? It's not where the physician doesn't know, it's where you have the feeling that you don't know something enough, that you cannot explain it properly. So what, if, I don't know, maybe you know enough, but what would you say on that?
I really wish my doctor knew more about it, because I don't know a lot. I know some about it, but I don't know a lot.
Sorry, what would you like to know more?
What would I like to know more about?
Yeah.
About my eyes.
Do you feel like you have enough support at home for the visual issues that you have? Like, do you feel like you can get around very well?
Oh, at home? Oh, yes.
Do you still cook and do different things like that?
I don't cook as much as I used to because I have trouble with my eye.
Well, Christian, we have a video series for patients with low vision, and it was really created because of you and Aiden and a couple of other of our patients. And we need to see if there is a low vision specialist in your area that can do like low vision therapy with you. They can show you different tricks that you can do. I'll watch those videos again with you, or whatever we can do to help. But is there anything else that you wish that you knew about ATS?
No.
And what about you, Andrea? Do you think there is something, an area where you would like to, or Aiden, do you think that Aiden, it's difficult because there's also different level of education. If we want to educate the patient that are teenagers, it's not the same as educating the parents or a patient who's 40 years old.
I think Aiden is in a little bit of a fortunate situation with me running the nonprofit. We've done lots of traveling, and so lots of phone calls that he's been privy to. So I think Aiden could actually educate a lot of the physicians about ATS and about the mechanism behind it. So I don't think Aiden is the best example on that, but there is an area that I feel that is very understudied. One is the carriers. And I love that someone else pointed out, until we have those publications, the doctors just ignore us when we try to go to the doctor. And not all of these rare connective tissue disorders are autosomal recessive like ATS. So carriers can have some mild manifestations, but until we get those papers published, there's just not a lot that our carriers can do, which is and I know that has to do with, the other conditions in different areas. But something that I wish there was more information about was, I just wish there was more basic science. It doesn't matter how much basic science we have or where we've been, it's still not enough to get the answers that we need to have the appropriate treatments. Right now, we're just treating symptoms, but it would be wonderful to be in that position where we could actually treat the reason why the symptoms are happening. That's it. That's all I got.
Thank you. That's a lot. Dave, I doubt that since you have your daughter with you, I doubt that you are missing some information from your side, but if you have any comments on how to educate the patients in cutis laxa, if you have contact with other patients, do you have the feeling that there's an area that they don't know enough, where they don't know enough to be able to really have a dialogue with their physicians?
Yeah, you're right. I have Dawn, so I get those answers. But I think I rely a lot on, for cutis laxa anyway, the cutis laxa website. I think we could make those sites, the advocacy groups could make those sites a lot smarter to the idea of bracelets and things, but even to, if you could have kind of a question and answer thing that you could do, pull up on your phone that goes direct to symptoms or diagnosis, those kind of things. I don't think technically, I happen to run a technology company, I don't think it's technically hard to do that, but the knowledge is the hard part. So, oh, sorry, my watch decided it should check in. What? I see that. On the other, I saw that Gina had posted about educating doctors and physicians. I think that's the bigger problem. And how do you get them interested in getting educated? It's a tougher. I've tried to address it. I have a foundation called thinkgenetic.org. It gives out education grants to medical professionals in specific diseases to say, we don't tell them where to go or what to do, but we say, we'll give you money to go get smarter about something, pick your disease. So it's not just about connective tissue. So you're welcome to take a look at that site and apply if you want. We've given out, I think, 10 education grants so far this year, and we'll do more. We get funding from the pharmaceutical industry to give these grants to various people. So we try and make it more agnostic in that we're not focused on a particular disease, although I care about cutis laxa, but there are a lot of others. There's 9,000 of them. So feel free to take a look at that if that's something that your professional caregiver could use. And I would keep coming back to genetic counselors to say they're really the ones that will understand genetic kinds of conditions. So you have to either educate one or get someone interested in your particular condition. If you do, they'll spend the time with you to help. That's what they're trained to do. So that would be my one going forward comment where you could get help.
Thank you very much.
Following, we have Gina. So Gina, you're an expert in your disease, but if you have any, you're representing the Marfan people. When you meet new patients and newly diagnosed patients, do you have the feeling that there is something that they don't understand from the handbook, or where there should be more focus on the patient education?
As far as the doctors don't understand, is that what you're asking? That the doctors don't understand?
No. What the patient doesn't understand.
Oh, a patient.
Where the patient has difficulty explaining because they have a lack of knowledge of some of the aspect of their disease, or I don't know, fundamental biology. It's not that we are going to make all the patient PhD in biology, but a minimum to be able to explain.
Yes, I think the basic biology, anatomy of the heart is the biggest barrier for patients to be able to describe their symptoms or their concerns. So we know the heart is a complex organ, and it's not just the heart, but it's the aorta. And a lot of patients really don't understand the connection between the heart and the aorta very well. And patients have difficulty describing their pain or their symptoms or their concerns because they just don't have the knowledge. They just don't have the information of the aorta. The aorta is this kind of mysterious part. Where is the aorta? You know, in specifically American culture and anatomy and biology classes, up even into high school, you learn about the heart, but the aorta is not, there's no instruction on the aorta. And particularly people with Marfan syndrome and Loeys-Dietz and vascular Ehlers-Danlos, it's the aorta that is most critical. And so if patients could understand the function of that piece a little bit better, then they could be more equipped when they are going to the emergency room or they're going to their doctor, and they could have a more informed conversation with their specialist about what the specialist is recommending as far as treatment for medications or treatments for surgeries, as far as aortic replacement or what procedure they need to have to repair an aneurysm or to repair a dissection. That piece, I think, is critical to helping patients understand how they can advocate for themselves as well, so that when they go into the emergency room and they say, I have chest pain, instead they can say, I am at risk of an aortic dissection. I am requesting a CT angiogram or an MRI or an MRA to visualize my aorta to either rule out or rule in an aortic dissection. That is the phrase that's going to get the clinician's attention in the emergency room or in the doctor's office, because then that shows the clinician, oh, this person knows a little bit about their anatomy. Oh, I need to take this patient a little more seriously. And then the clinician can ask follow-up questions. Well, why are you requesting this? I have Marfan syndrome. I have vascular Ehlers-Danlos. I have Loeys-Dietz. My tissue is fragile. My tissue is susceptible to dissection at any moment in time. I just had my third open heart surgery about 3 years ago. And after the surgery, my surgeon told me my tissue on my aorta was like butter. And if you can imagine, operating on butter is probably quite challenging. And thankfully, I was at a medical center that knew how to treat my tissue. But I feel for the individuals who are at medical centers and hospitals that don't have that knowledge, and the clinicians don't know how to manage tissue that is fragile, that is like butter. So for patients to be very well versed in the right words to say to trigger those clinicians in the treatment of care that is best for them.
I would reinforce what she's saying, having just lived through almost a dissection, that the problem is if you come in with chest pains or your heart hurts, they're going to do pulse and they're going to do a lot of things, but they're not going to look at the aorta, and it could be getting ready to go, and they would never see it. So like in my case, it was just serendipitous that they did a chest x-ray and spotted the aneurysm. I never had any symptoms. So you would go on living with that, and unless you have some other reason that makes them, and Marfan's is a perfect example, or Ehlers-Danlos or cutis laxa, that's the first place they ought to look. And they don't do the CAT scan or the angio, any of the things that they really need to do immediately, because that's the risk you have. So, and that, in fact, now it's in my medical record. Whenever I go to the emergency room, that's the first thing they do before they even worry about anything else. You know,
yes.
Stub my toe. That's what CT scans scan.
Yeah, and in the Facebook support group, there have been patients who, you know, they comment in the support group that they did a chest x-ray and they were sent home, but they didn't have any further imaging to visualize the aorta more clearly to be able to detect a dissection. So, you know, a CT angiogram or an MRA. And I even, you know, a close friend, she went in and she was, you know, having classic chest pain, and she was in the emergency room for several hours before she decided to ask, you know, can we just do a CT angiogram just to rule it out? And lo and behold, after hours she had spent in the emergency room, oh, yeah, we see a dissection. Oh, we didn't anticipate this. And she was there for hours and hours before it was imaged and identified.
Yeah, impressive testimony. In fact, your what I take from that is that the education would be important to have the knowledge to describe the risks and the symptoms. So for Marfan, it will start with the anatomy of the heart and more aorta. I think this would be something common to so many of you. Andrea, what do you think about that?
I am in total agreement. Absolutely.
Yeah, I don't know all the conditions, but I know Ehlers-Danlos, Marfan's, cutis laxa, all of those related. It's the first thing. I mean, that's the risk, and it won't show up anywhere else necessarily.
And I think it's important for patients to use the right terminology, to use the biological terms to communicate with the clinician, to not just say I have chest pain or, you know, my stomach hurts, but to really use those biological terms. That's going to catch the clinician's attention and take them more seriously and be more willing to follow through with the more invasive imaging and assessment pieces when patients use the correct biological terms.
Yeah, my daughter told me to use AAA, ascending aortic aneurysm. I can always remember the words in the right order, but I can remember AAA. So,
well, I'm very grateful for David, you and Gina's testimony on all of this, because I think it's really enlightened a lot of us how we can do things a little bit different when approaching our conditions. Because I think a lot of families are intimidated by the big words. And, you know, sometimes they only want to know enough to let their doctor know what they have. But the problem is that we're having to teach the doctors about our condition as we go along. So I think that's a great way that I can work with our population too, is, you know, helping them understand, you know, those technical aspects of the condition. And we try. It's just some people just, they don't want to know any more than what they want to know. And I totally understand that. But when you are in that type of situation, and I think that's where your story is so important, is because it really puts it into perspective, how important knowing those terms and the anatomy and things are when a crisis does arise. So I appreciate you both very much.
Jade, we are missing your testimony on that.
I think it's not just adult patients knowing the biological terms. I know with Gavin, I started young, like kindergarten, preschool. I think when a teenager and a child knows the biological terms and say, you know, my calf muscle or whatever they can communicate, the doctors do take them seriously. I know when Gavin he's about 6 or 7, he told the doctor, I do not want no more liquid medicine. I refuse. I will not take it. I want pills. And he's talked so clearly and communicated so well. They said, okay, they listened to a child. And I think that's important, that we teach our children the realness of their disorder early, so they become more comfortable older doing exactly what everyone else is saying. For those conditions that are discovered in childhood. I know not all of these conditions are discovered in childhood, but if you do have a child, I think it's important to teach them, you know, we're going to the cardiologist for XYZ. We're going to the GI for XYZ. So they're educated, because there's going to be a point where they take over.
Well, and when they're born with it and they grow up with it, they listen to us while we're talking to the doctors, and you'd really be surprised what they pick up on. Because I had Aiden come home from a doctor's appointment and say, okay, Mom, what was Dr. Fontenot talking about such and such? And so then, you know, we went into a discussion and I explained it to him. And I think that's the best way that we teach them to advocate, is be honest with them. We don't have to talk about all the gloom and doom and the scariness and the life-threatening portion of it. But it also doesn't hurt to let them know, like, there are things that we need to be concerned about. And this is why you are not allowed to play football, or maybe you should find a different activity that puts less stress on your heart or whatnot. I mean, I don't think that there's any reason to not have those honest conversations with them, because it just makes them grow up to be better advocates, and we can rest a little knowing that we've taught them well.
And on that part, siblings also.
Yes.
I know Gavin's youngest brother wants to be a cardiothoracic surgeon because his brother needs heart repairs. He's 9. I think it's important we include siblings in the conversations, because a lot of times they feel left out of the circle, if you say, and it's sometimes detrimental to their mental health and the family structure when they are.
Yeah, I totally agree with the siblings. They stay silent, but they are in fact totally involved in everything. Well, that's so that ends for the panels. So now I would like to open that to all the audience. If you have any comments to add or other ideas about what you feel, where you feel you should be educated more to communicate properly with your physicians. The panelists were so great that nobody has any comments. They said
Hi. Thanks, everybody. This has been a great to listen to everybody. I'm in Toronto, in Canada, and my son goes to Sick Kids, which is a pretty good system in general. I mean, I have a laundry list of complaints, but I always will. They're mostly bureaucratic and systemic from the organization. I think he gets good treatment, but it did take a lot of work to get there, and mostly by my wife being an advocate to get him classified as complex. And I don't know if that's something that exists in the US or in Europe, but getting him into this sort of list, which he really, according to the rules, shouldn't be in anyway, really was a game changer. I mean, people take note of him when he walks in the door. It's basically it's a frequent flyer card for the hospital. The hospital for us is our primary care physician, because most of the people in Toronto can't figure out what to do with Henry. The other thing that we've done on top of that is to put together a quick reference sheet, and it's really more for urgent care, but it's a list of things not to do. Rather than try and explain Myhre syndrome to everybody that we run into, which is a waste of time mostly. It's do not do this, do not do this, do not do this, and that usually drives the conversation better than, you know, he's got a rare connective tissue genetic disorder, which, you know, people go, yeah, okay, like, we got to treat him, so get out of the way. And by advocating in that sort of like, we're gonna fight you if you try and intubate him wrong, you know, it makes people stop and start asking questions. So I wanted to add that. Otherwise, I think I don't have anything new to add. Kate, by talking about how important cardiac is, you know, illustrated what's really, you know, most important for Henry and for the Myhre stuff that we deal with. But we're very lucky to have. I know, he's amazing, right? Oh, don't get hurt. That the hospital doctors do try and work together as much as they can to collaborate on what's going on with him, and not sort of treat symptoms and sort of whatever their narrow specialty is. That's all I had. Also, done 25 years in software. So if anybody wants to message me about ideas for software stuff, I'm happy to chat. But unless we can invent a way to beam stuff from your iPhone into your doctor's brain, I will see how helpful this stuff is.
Matthew, thank you so much for sharing that. And my email is in the chat. I actually have a project that I'm working on where you might be interested in being involved with us. Please email me.
Will do.
I'm also in Canada and on the West Coast though. And I agree with Matt as far as if you can get your child considered complex, it does open some doors as far as having people take you more seriously. I know at our local hospital, Karis's pediatrician has made her, they call it a VIP. So, you know, if her family doctor is not available or her pediatrician is not available locally and there's an issue, we can go straight up to the pediatric floor and see the doctor on call and bypass sitting in emergency for hours. So that, you know, things like that are helpful. I'm fine myself communicating with doctors. I've worked in healthcare for years. So the problem I don't find is necessarily on my end. The problem is getting the doctors to understand, because I just don't have the knowledge of Myrie syndrome. So we'll go into a specialist and at our children's hospital, you know, cardiology, for example, and they will say, tell me everything you know about Myrie syndrome because we know nothing. And those are the people you're looking to for expert opinions and help for your child. And they're essentially telling me, we know nothing. What do you know? So I think there is a big gap on knowledge and how to educate these professionals the best we can. And the onus really is, like everyone says, the onus is on the parent or the patient.
Yeah. So that's I think it's extremely important that the patient really are in control of the way they express all of that, because you cannot count on the doctors to be all specialists of your disease. You are the one. Yes. Danielle, you have a comment?
Yeah, my husband has.
Hi, thank you so much to everybody. It's been quite enlightening and comforting to hear all these stories. Don't have too much to add because everything's been said very eloquently by everybody and whatnot. We also are in Canada, in Montreal. And we're pretty lucky in the sense that I work in the healthcare industry and my wife is very active in the Myrie community. So the combination of us together, we can get quite far, as well as our pediatrician is phenomenal. Another Myrie case in Montreal, which we happen
Maya Z, she's really helped us.
She's helped us, and also we have amazing specialists that have already, some of them dealt with Maya, so they're already a little bit in the loop. The only thing, and I think these ideas of QR codes and everything, that's the biggest struggle I think we all have is communicating when, especially in emergency situations. The only thing that I want to add was something that was brought up to us last time we were in the emergency room. It was something, I'm not sure how you say it in English, but in Quebec, it's called a pivot nurse, which is kind of an intermediate, basically a middleman between specialists, which that was kind of a program they're starting at the Children's Hospital here in Montreal. And it might be something that could be very beneficial to other people. And we're waiting for feedback on this topic, is because we're hoping that this position,
have a coordinator.
Yeah, basically to have a person that is kind of there to, I mean, we're all going to be advocates for our child, obviously, and be specialists in our own right. But to have somebody there as a resource, a professional resource for these other specialists and maybe emergency physicians and whatnot and nurses, that they can call and say, you know, we need more information, and they can basically, I guess, dumb it down for that specialist at that time, could be very beneficial in that situation. Kind of another cheat sheet, but like a human cheat sheet for them, you know? So just wanted to add that. That's a possibility as well, you know?
That's a great idea. So it's a kind of coordinator that would know about the disease and know what to ask and where to go and how to contact, make a link between experts and.
Yeah, I mean, like I said, our pediatrician is so amazing. We're so lucky that he's already kind of like that. But you kind of need somebody. You know, pediatricians are very busy, and a lot of people can't even get a pediatrician. So, yeah, exactly. It's a person, and I mean, they're not going to be experts at first, obviously, because nobody is until it happens to them. But they will become experts, and it could help for sure.
Hi, Daniel. This is Andrea Taylor. I want to ask, do you guys have a lot of genetic counselors in your area?
We have our specific genetic counselor who was amazing. And then they gave us, we had therapy after our genetic diagnosis, and any questions, they are readily available for us to ask questions. Beyond that one, we only have 2 that we deal with specifically, but our 2 are amazing, they're always there for questions.
Fantastic.
Yeah.
How long did it take for you guys to get your diagnosis?
When she was born, she failed her hearing test at birth, then had the sacral dimple hypertonia, had delayed myelination on the brain. So we, I think, started around 9 months, and then we had a diagnosis maybe 9 months later. So by close to 2, we had our answers of what was going on. So we're almost a year since diagnosis.
That's pretty quick. And I feel like sometimes the diagnosis is coming faster, but we still have so much work to do in that area as well. Your family is beautiful, and we're very grateful that you chose to spend your morning with us today.
Oh, wonderful. No, thank you so much.
I think we are getting to the end of our time. So that was the last panel that was foreseen. And so the next time we get together will be for an interactive webinar. We have monthly meeting with the team of CONECT, where we are going to discuss the analysis of all these panels and decide on the different webinars educating the patients. So I think we got quite a few ideas now. If some of you have the feeling that the discussion should go ahead and you want to participate more in the discussion, I'm sure you can contact Andrea and we can see a way to go further with discussions. I don't know, that's a Zoom meeting, so it's an easy way. It's not like having a convening in person where it's extremely difficult to get some, but we can be, I don't know, Andrea, if you agree with that, but we can be flexible in having a Zoom for an hour or 2 on something you want to discuss just with a few people. We don't need to be all together, or doesn't need to be extremely official, or, but we can always, the idea is that we get together and we talk about the issues, ideas, brainstorm, and go ahead. So, Andrea, I don't want to talk from your sides, but not every day, of course, but
I'm so glad that you brought it up, Armel. We have a lot of the same thoughts on some of these things, and I was actually thinking about that we need to have, maybe we set up something where we have a once a month just group session where we get together outside of the actual program meeting. And if you can join, if you can't, but we'll talk with some of the other patient group leaders and see maybe a couple of dates that might work per month. And if I can't run the meeting, then I can give access to our platform so that we can get those set up and we can continue on. Because I think what we're doing here has extreme value for all of our patient groups. And, you know, individually, when we try to educate our providers, yes, we can do a great job with the providers that we work with that specialize in these particular conditions, but we're missing so much, and we can only do so many things. And, you know, each person can only be good at so many different projects. But I think if we work together, we can really use each other's skills and really work hard to educate providers in a different way. And I have a great feeling with all the things that we've learned today. I know I've been taking notes. I saw Armel was, and we'll definitely go back and watch the recordings again. So yeah, I think that's great. I'm sorry, that was a long answer to a very quick question.
It's just, for example, in our disease, cure VCP disease, we have a happy hour in the evening, around 6 or 7 Eastern time, so that people from the West Coast can also join after their work. So that can be something like a happy hour, and it's discussion just about what you have on your heart and new ideas, and nothing really set in advance, just an hour together and think together or share together or whatever.
I think it's great. I think we should do it.
And for Kate and forgot your name, of course, and Ines. So Andrea would like to maybe have a conversation where I can translate. So maybe we can just have a discussion, half an hour, so that he can express what he wants to express, because he couldn't follow the whole thing. So that
would be amazing. Yeah, thank you. Yeah, thank you so much.
Just send me a Zoom invite and we'll get together. Okay, well, hope to see you soon in a happy hour with a glass of wine, or no, I shouldn't say that, with a glass of water or soda, or no, soda is bad, even worse than wine. So thank you for all of you to join us, and thank you to Andrea to have the idea that we should get together. That's fantastic. So have a nice weekend and hope to see you soon.
Thank you.
Thank you, Armel.
Thank you.